Hi, everybody. I'm Tom Powles. I'm an oncologist from London. I'm really delighted to be invited here today by the OncoAlert team, their 2025 year in review. I'm talking about bladder cancer. And goodness gracious me, wasn't it an incredible year for urothelial cancer? With so much I could talk about, I'm going to focus on the three plenary sessions from ESMO because it makes sense. And that is neoadjuvant enfortumab vedotin and pembrolizumab versus cystectomy alone, number one. Number two is ctDNA in muscle-invasive bladder cancer. And then number three, DV toripalimab in advanced disease. All three positive trials with an overall survival benefit. Let's start with EVP in cisplatin-ineligible muscle-invasive bladder cancer. Enfortumab vedotin is an antibody-drug conjugate. It targets Nectin-4. It has MMAE as the payload. Pembrolizumab, as you all know, is an immune checkpoint inhibitor, unless you've been living on Mars or something. And that combination really outperformed platinum-based chemotherapy, twice as good as platinum-based chemotherapy in first-line metastatic disease. So what happens when we stick it into the perioperative setting? What happens when we compare it in those patients who are cisplatin ineligible, so those patients who are getting cystectomy alone? Can we beat cystectomy alone with perioperative EV pembro, 9 cycles in all, in a modest size randomized phase 3 study? Notice here it's only 344 patients. Also notice the pembrolizumab arm was not presented. So this is the cisplatin ineligible muscle invasive bladder cancer, cystectomy alone, the standard of care. Here's the event-free survival. And it's striking because it's so positive, a hazard ratio of 0.4, a spectacular result showing two things. Number one is EV pembro is outperforming cystectomy alone. But secondly, look at 24 months. You've got here 60% of those patients who receive surgery alone relapse. And that means they've almost certainly got advanced disease. They've already certainly got MRD at the time of surgery. And look how steep the first part of that red curve is. What this tells us, I think, is that muscle-invasive bladder cancer, for the majority, 60% of patients, it's already advanced disease. And giving systemic therapy first makes a great deal of sense. And can we select that 40% of patients that don't need treatment? I'm going to come to that in a minute. But overall, this is practice changing. But it's not just event-free survival. The path-CR rate is striking at 57%. If you're giving a systemic therapy with nearly 2/3 of patients or 60% of patients getting a pathological complete response, no cancer left in the bladder, do we need to be doing the operations, this once in a lifetime operation on these patients? Do they need to have that operation? And I can see we need to do trials to explore that. And also on the right-hand side, a significant overall survival advantage. Remember, none of the adjuvant trials, adjuvant Nevo, adjuvant Pembro, adjuvant Atezo in unselected patients, none of those achieved OS. Only NIAGARA and this trial, NIAGARA, GemCis, durvalumab, neoadjuvant, and this trial have achieved that. One has to talk about adverse events, and we know that enfortumab vedotin is associated with skin toxicity and neuropathy. This shorter period is probably slightly better tolerated than the longer periods of therapy, in my opinion. And number one, of course, pembrolizumab, some life-changing toxicity. Key question, and we know at ASCO GU we're going to see the same regime, EV Pembro, going head-to-head with GemCis in the neoadjuvant setting. Now, we've seen this with NIAGARA already. NIAGARA did GemCis with durvalumab, and we showed the addition of a durvalumab had a 10% bounce in pathological complete response, an EFS hazard ratio of 0.68, and an OS hazard ratio of 0.75. So we're going to be making inevitably some indirect comparisons between these two trials. I think a path-CR rate above 50%, I think that's a big statement, and we saw that in the previous trial. The rest, we'll have to see how we get on. But in the end of the day, bladder cancer is changing, it's changing fast. We're seeing transformative data now in the perioperative space and a change of standard of care. Surgery alone, in my opinion, is no longer the standard of care. It's systemic therapy first. The next study is circulating tumor DNA. I'm going to talk about IMvigor010 first. This was the retrospective analysis that prompted the randomized phase 3 study, IMvigor011. This retrospective analysis of a negative adjuvant trial. So these patients have not had prior immune therapy. They've had surgery. They're radiologically negative. They got adjuvant atezolizumab or placebo, unselected. The trial overall was negative, but we identified the positive patients. On this slide, you can see the ctDNA positive patients in dark red, almost all of them relapsed. Whereas the pink patients, the ctDNA negative patients, about 30% relapsed. So we can identify this higher risk group. And indeed, in this higher risk group, those that got atezolizumab gleaned clear benefit with hazard ratio of 0.6, but the negative patients who received therapy got no benefit with hazard ratios above 1. And so what this suggests is it's prognostic. The patients are doing obviously much worse who are positive, but also predictive in that it's working in the positive, but not working in the negatives. And so the question was, can we prospectively validate this? And that's what IMvigor011 was all about. Here is IMvigor011 design. It's the same population. It's muscle-invasive bladder cancer, radiologically negative disease. ctDNA positive patients are then randomized to atezolizumab versus placebo. ctDNA negative patients are monitored. If they become positive, they're also randomized. And if they remain negative, they're on surveillance alone. And when you look at the overall outcome of these patients, what happened, about half the patients were negative and remained negative throughout. And the other half were either positive or were negative and became positive. When we look at the primary endpoint of the study, we can show it hit an overall survival benefit for the ctDNA positive patients with a hazard ratio of 0.59. It also hit DFS and also had higher ctDNA clearance. These findings didn't just occur in the positive patients at baseline, but also in those patients that became positive in the forest plot analysis. ctDNA was again strongly associated with the benefit of the atezolizumab. And then in those negative patients, those patients that were negative who remained negative, those patients had excellent cancer outcomes. Now, there is some censoring in these curves. And of course, any randomized phase 3 is not perfect in that respect. And there were some patients who were at the beginning ctDNA positive, negative, who became positive, or ctDNA positive, who also had radiological disease at that time, and they weren't randomized. Nevertheless, when you look at this overall, you can make 2 or 3 conclusions. Number one is ctDNA positivity is associated with high risk. Number 2, it is predictive of benefit, and if patients are positive or become positive. And number 3, those ctDNA negative patients who remain negative, about half the population, have excellent outcomes, and you're sparing these patients life-changing toxicity. Now, this needs to be in the context of the knowledge that none of the adjuvant trials, like the adjuvant nivolumab trial or pembrolizumab trial, have achieved an overall survival benefit. So in unselected patients, there's no benefit. Here, we've identified a subgroup where we can identify those at real risk that glean benefit, and we also sparing those negative patients life-changing toxicity. The Tombola trial is a Danish effort, an amazing publication recently in Annals of Oncology. This is an important study because this did a similar thing. The negative patients who remain negative on surveillance, the positive patients, or those that became positive received atezolizumab. Again, robust follow-up in this national series for overall survival. And you can see here those patients who were negative and remain negative, excellent outcomes of 100%. So this reinforces what I said before, is that we can track these patients. We can rescue those patients that become positive with atezolizumab, and we can spare those patients who are negative, life-changing toxicity. And then we look at the current standard in this environment, which is nivolumab, and nivolumab hit a DFS advantage, never hit an OS advantage. And then the recent ctDNA analysis of this population shows very similar things to IMvigor010. In the positive patients, so those at risk, have a clear benefit from nivolumab. The negative population, not only at much lower risk, but no significant benefit associated with the addition of nivolumab. And remember, of course, these patients who are at lower risk, getting no benefit, in harm's way from life-changing toxicity. So a compelling story when you pull that together. When we look at these two trials I've just said, we integrate them together, the future does tell us one or two things. Number one is we're going to be giving systemic therapy in the future, in my opinion, not surgery. One of the challenges with IMvigor11 is it tells us when to start therapy in the adjuvant setting. It doesn't tell us when we should stop neoadjuvant therapy from NIAGARA or indeed from the EV303 Keynote 905 trial. So it's helpful because it gives us a new tool, but most patients won't be receiving adjuvant therapy, I hope. I think the treatment will be given earlier. There is then, of course, that key question is, do we need to do the surgery? I'm not convinced we do in all patients. And we're going to do trials moving forwards, looking at muscle-invasive bladder cancer. And this is a trial that I'd like to see done, where we have muscle-invasive bladder cancer. We give EVP first, ask questions later. If we haven't achieved that CR, we then may be doing surgery or radiotherapy on those patients. But those patients that have clinical CR, using cystoscopy, using maybe ctDNA, when we look at these negative patients, can we keep going and spare their bladders with 9 cycles of EV pembro? So that's the first two trials. The third, I'm going to be faster. My great friend and colleague Jun Go presented this at ESMO. This is frontline metastatic disease. The trial design is very simple. DV toripalimab versus chemotherapy. Disitamab vedotin is a HER2 ADC. It's given in combination with a PD-1 inhibitor, which is used widely in China, toripalimab. It's compared to classic gem-cis chemotherapy. It's frontline metastatic disease, cisplatin and carboplatin populations. And here you can see hazard ratios really striking for disease-free survival, about 0.4, OS about 0.5, actually very similar to what we saw with EV302, EV pembro versus chemotherapy. Disitamab vedotin is a HER2 ADC. It has MMA as the payload. So it's quite similar to EV, but the target is different. And so in this trial, we only included patients that expressed HER2, either 1, 2, or 3 plus. So patients had to have a pathology review before getting into the study. That's one of the distinct features. The second distinct feature with this is DV is associated with less skin toxicity, but the overall adverse event profile is probably quite similar, actually, maybe more fatigue. We haven't got direct comparisons, but I wouldn't say this is easier to tolerate than enfortumab vedotin. And then the third issue, which is worth discussing, is although the response rates were high at 76%, the complete response rates were lower at 5%. Remember, EV pembro was 30%. So that's something which I think we need to see more follow-up on. But this is clearly a really active and great regime and an attractive alternative to EV pembro in this setting in those patients that are positive for HER2. This slide gives a slight, cross-trial comparison. I know it's really naughty and I'm not supposed to do it, but I'm going to anyway. And here you see EV pembro, DV toripalimab. You can see the efficacy signals from response, EFS and PFS, quite similar to each other. The EV pembro has longer follow-up. It's a much larger trial. I think that's very fair. It has a higher complete response rate, as I said previously. It's not in a select population. Overall, I still think EV pembro is the standard of care in this setting because it's unselected, number one. Number two is that we're seeing more robust, longer follow-up. But DV toripalimab, a very attractive alternative, in my opinion. What do we need to see for DV toripalimab in the future? Well, of course, as with EV pembro, what's the duration of therapy? Is it treatment forever? We had a debate recently at the AUC3 meeting around this area. I think most people haven't yet made their minds up about how long we should be giving these therapies for, number one. Number two is, do we know enough about the HER2 biomarker? And the answer is, I think there's a lot more that we need to learn. I'm really not convinced. Even in the HER0, we've got super robust data. I'm not convinced by that. I know others are. We're going to see more data with disitamab vedotin from a global trial outside of China at the upcoming ESMO meeting. And so therefore, what is the global reach of this study? Well, when you have EV pembro, do you need DV toripalimab? Most people feel there may be cross resistance between these two because they have the same payload. And so we have to see sequencing trials before we're happy giving these drugs in sequence, in my opinion. And then, of course, can we move DV toripalimab into the perioperative setting, as we've seen with EV pembro? I think you could, but a randomized trial of DV toripalimab versus EV pembro in the neoadjuvant setting, I think that would have to be a non-inferiority trial because I don't think DV toripalimab would beat EV pembro. Maybe there are other designs we can come up with in the future. And then, of course, I always show this slide. There are so many new treatments coming through. SAC-TMT, I showed some good data in lung cancer. Isabren, the HER1, HER3 ADC, that's in randomized phase 3 trials. Dato-DXd, also in urothelial cancer. We've got the bicycle drug. There's some Me Too EV drugs kicking around, which are potentially attractive as well. So much going on. So I've gone on long line of light. What have I said? Number one, I've said that bladder cancer is transforming so quickly it's hard to keep up, and I think that's true. We saw the first trial with EV pembro replacing surgery, making systemic therapy the new standard. No longer surgery is the first port of call. We were looking forward to more neoadjuvant EV pembro data in the future. We saw the second trial, same space, perioperative, but this is the adjuvant rather than neoadjuvant space. And we showed ctDNA focusing on patients at risk in the adjuvant setting, prognostic and predictive, and those negative patients doing really well, number one. Number two, we showed other trials showing those patients doing well as well. And then number three, of course, those negative patients potentially being spared life-changing toxicity, and heaven forbid if their cancer was to come back, they could get frontline metastatic EV pembro, which sounds attractive as well. And then the third study, DV toripalimab, out of China, randomized phase 3 study, certainly practice informing, practice changing in some parts of the world, China already. Whether it will displace EV pembro, I don't think it will do that, but it is an attractive alternative. And we're going to see more global data for the disitamab vedotin in 2026. I'd like to thank you very much for your attention. I hope I haven't talked too fast. I had so much I wanted to say. I've enjoyed this very much.